All right, in this talk, we are going to go over first some pleural issues. So, some sort of abnormality with the pleura. Oof, I just had a weird inhale. Sorry about that. So, some sort of issue with the pleural space. And then we'll get into what we call parenchymal disorders. Parenchymal. And the parenchyma is the functional tissue, not just of the lungs, but really of any organ. So parenchyma, that's your vocab word of the day. All right, so we'll start out with pneumo. So pneumo is lung, and thorax is referring to the thoracic cavity. And the thoracic cavity is everything essentially above the diaphragm. So this is when we have some sort of alteration to the pressure gradients involving the lungs and the pleura. So if you remember, this pressure inside the pleura, so this intrapleural pressure, should be relatively low because there is really just these two really thin pleural membranes. One of them is going to be lining the lung itself. So that's your visceral pleura. Visceral means inner. So we've got our visceral pleura. And then we have the parietal pleura, which lines the chest wall and goes all the way to the diaphragm. So when the diaphragm pulls down to its contracted state, this flat state, it pulls down the pleural membranes in the lungs with it, which allows the lungs to expand and airflow in. There is a higher pressure inside of the lungs, so this pulmonary pressure, and this pressure gradient allows this fluid essentially in the pleura to form a vacuum-like pressure that keeps the lungs. Is that how you spell vacuum, or is there one C? I don't know. You guys, I won the spelling bee in 3rd grade. That was a long time ago, so don't judge me for my vacuum spelling. I'm pretty sure there's only one C. Whatever, we're not talking about vacuums right now, but we are referring to these pressure differences. So if there is anything that disturbs this pressure difference between pleural pressure and intrapulmonary pressure, we no longer have this vacuum that is going to allow the lungs to stick through the pleura to the side of the chest wall. So if there is any disturbance of this, like let's say like a bullet wound, so some sort of bullet that comes in here, or a stab wound. This can also occur spontaneously. Most common age group is males, 20 to 40. And this seems to be associated with things called blebs, which are kind of, so they're little things that exist along the lung and or the pleura that can alter this tension and that causes the lung to collapse. And that's how we really define pneumothorax. It's a collapse of the lung. And this happens as a really protective mechanism, actually, because if there's anything that comes in here and destroys this pleural space, this pleural space pressure, this pressure gradient, what it does is create this open wound. And if the lung does not collapse, we now have the opportunity for something called a sucking chest wound to occur. Because just like if you lose a little bit of residual volume when you get the wind knocked out of you, remember there should be about 1.5 liters of air in the lungs at all time, this residual volume that allows the lungs to stay inflated. If any of that residual volume is lost, the diaphragm will spontaneously contract and contract and contract to induce airflow to reinflate the lungs. So what that means in the case of a wound, if the lung doesn't collapse, we can have air sucked in by a function of this reflex of the diaphragm. And we now not only have the opportunity for hyperoxygenated blood, which almost appears this pink color because it's hyperoxygenated, there's also the increased likelihood of what we call an air embolism. And an embolus, remember, is anything that's traveling through the bloodstream that's not blood. So it's not supposed to be there. And so if air gets sucked in and then enters the circulation, the heart is only equipped to beat and handle fluid. So when air gets into the heart, it stops. So it's really deadly. We don't want that to happen. So what the lungs do is collapse. So what we see here in this picture, so I'm trying to erase this here, and it's kind of working. All right, so what we see here again is, there we go. So on one side, we have a normal lung that has not collapsed. So over here, we've got a normal lung, and we can actually see the bronchioles illustrated in this picture. And on this side, we have a lung that's collapsed. And so we see this pleural line, and we see the lung, the parenchymal tissue of the lung that has compressed itself essentially in the thorax. So if you're looking at imaging, there's a couple of things that let you know that it's a pneumothorax and not something else. So when there is a spontaneous pneumothorax or a pressure gradient pneumothorax, I want you to notice the trachea here. The trachea remains in the midline. So it's at this middle portion of the body where it's supposed to be. We also see that relatively the diaphragm is located in the correct location. So in pneumothorax, we would see generally the mediastinum is in the place where it's supposed to be, the trachea has not shifted, and the diaphragm is relatively in its position too. Just a little note, there's also something called tension pneumothorax, and tension pneumothorax can occur when there is not enough air in the lungs itself. And that could happen for a variety of reasons, like abnormalities in blood flow. That can happen with inadequate oxygen into the lungs. So let's say like after open heart surgery, for example, it hurts really bad to take a full inhaler, forced expiration. And those mean respiratory therapists or nurses, they come in the day after surgery, and they ask their patients to exhale fully into this forced expiratory spirometer and move that little bead on the spirometer. And what they're doing is forcing this exhalation and then inhalation to fully inflate the lungs, because if there is inadequate filling, then we have the possibility of lung collapse. So pneumothorax, collapse of lung due to, generally air in the pleural space, which disrupts this pressure gradient. Again, we see trauma causing this. So shot with a bullet, broken rib is another thing that can cause that. If a rib breaks, it can puncture the pleura. This can happen with aspiration of fluid, altering this pressure gradient inside of the lungs, because the lungs can handle air inside of the alveolus and really nothing else. And again, the spontaneous type of collapse in younger males because of a possible bleb formation on the lungs. And that collapse is something that happens in an adaptive way to close the defect and prevent this sucking chest wound air embolism, hyperoxygenation of the blood. And when a pneumothorax occurs, there's chest pain in the patient, there's dyspnea or shortness of breath, and reduced lung sounds on the side of the collapse. But we see the trachea, the mediastinum, and the diaphragm in the midline where they So what's a little bit different than this is atelectasis. So atelectasis is when there is a collapse of the lung, but it is distal to some sort of obstruction. So this can be due to a bronchial obstruction like mucus that lands itself in a bronchiole. This can happen as a result of a tumor growing inside of a bronchiole or a bronchi. And if we think about the tissue types there, that's epithelial tissues, and epithelial tissues are usually made of squamous cells, so things like a squamous cell carcinoma. This can also happen due to foreign object aspiration, so things like grapes. Great, I love honking outside. And like a hot dog. Those are two really common things to get lodged in a bronchiole. There's also compression atelectasis, which is when fluid alters this pressure gradient either through filling up the pleural space or filling up the lung space. So what you see, here's a normal lung. So this is the left side. The left side has a lobe that's not that's not there. Right side. So we see this dark coloration, which tells you that's intact parenchymal tissue. And then we see atelectasis. So we have one side that appears a little bit dense. And then when we have atelectasis, I want you to notice that we have the diaphragm that shifts up, and it shifts up towards the side of the collapse. And you also see this happening with the trachea. So we see the trachea is no longer in the midline, and the mediastinal structures are no longer in the midline. So that tells you actually the side of the collapse. So this side over here is the side of the collapse. And we can also see that because we don't have this normal coloration through this imaging. So it's not a full lung collapse. It is everything distal to this obstruction. So the area below the obstruction collapses. Okay, so it's not, again, not a full lung collapse like we saw in pneumothorax, where everything just kind of crinkles or crunches up to the inside of the thoracic cavity. We have the area distal to the obstruction collapsing, the diaphragm moving up towards the side of the collapse, the trachea and the mediastinum all moving out of the midline, moving towards the site of collapse. So those are some things you can see in imaging, or if you read them in a question, that lets you know that we're now looking at a partial lung obstruction that you see in atelectasis, which is different again from the pneumothorax, where everything remains in the midline. All right, so now we're on to pleurisy, which is an infection of the pleura. So pleurisy, so inflammation of the pleura. So the pleural space contains some pleural fluid, and there shouldn't be too much of it. It should be clear. And again, we just need a little bit of it so that we have this pressure gradient of low pressure in the pleural space and high pressure in the pulmonary space. If there is an infection, so this can occur due to a lung infection. When there's an infection, we get exudate development, fluid formed via inflammation, and that exudate can move, or the infection can then spread into the pleural space so that we get exudate development inside of the pleura, which expands the pleural space and makes inhalation difficult and also makes it painful because we now have a higher pressure here, which is going to limit in some way airflow. When there is a lot of exudate in this area, it can physically compress the lungs. Again, there's pain. When there is some sort of obstruction to airflow, remember that cough is something that exists as a reflex to clear that and enhance airflow. But we get restriction of respiration, of ventilation, which is breathing in and out, where respiration is our gas exchange, with this shortness of breath. This can also happen with any other kind of fluid in the pleural space. So blood can fill this. A tumor can cause this compression. And a lot of the time, this can get better on its own. So when the infection resolves itself, we can get reabsorption of the exudate. If it doesn't resorb itself, then we have to aspirate that fluid. And what is amazing about this, if you watch, go on YouTube, you can see a whole bunch of gross videos of an aspiration of the pleural space. And we can fit liters of of fluid in that space around the lungs. And even though they use a pretty large gauge needle, and it looks, just medieval when you watch these aspirations, individuals who undergo this say that the relief is just immediate and they can breathe again, and then the pain is reduced. So that's pleurisy, and inflammation / infection of the pleura. So this can happen because it is an infection that spreads outward from the parenchymal tissue into the pleura. This can also be an infection that starts in the pleura. All right. So when we're talking about infection inside of the lungs, one of the most well-known, I would say, is pneumonia. Pneumo, again, is lung. Pneumonia is a physical infection of the lung and then resulting acute inflammation. So we get redness, swelling, all those cardinal signs, and then eventually the development of exudate. And if it is an infection, we see that purulent exudate, right? That pus. It's not clear, it's heavy, it's yellowish or greenish. And if you've ever coughed up that purulent exudate before, it's thick, it's viscous. And in pneumonia, we see this exudate develop in the alveoli themselves. So it's an infection of the alveoli. And this exudate, because it's heavy, it does have a mass associated with it. And one of the dangers in pneumonia is the lungs picking up this mass, this heaviness. And then you're always going to get cough when there's mucus accumulating in the alveoli because, again, this cough is a reflex to clear these passages. So a danger is that with coughing, there can be so much force that it physically breaks some of the ribs. So you definitely see that these coughs should be inhibited, and they use pretty strong medications to do that, like hydrocodone, hydromorphone, which is dilaudid, and those work centrally in the brainstem area to physically inhibit the cough reflex. And pneumonia, there's lots of different types of pneumonia. There's postoperative pneumonia, when mucus and different secretions, they accumulate in the lungs. There's aspiration pneumonia, which is caused by aspiration of fluid or foreign bodies. The most common is some sort of bacterial or viral or both. When you have something called a bacteriophage, which is a virus that specifically infects bacteria. So you get this fun kind of superimposed infection. If you ever I'm not a microbiologist, but I feel like if I have to choose between one pathogen and another that causes a disease, usually strep is involved. Streptococcus pneumoniae is one of the most common pathogens associated with pneumonia. There's walking pneumonia associated with another pathogen. So usually it is named for the pathogen that causes it. The symptoms are going to be similar to what you see in other respiratory disorders. So cough, fever. They're pretty sick. The fever is relatively high. There's a lot of lethargy, which is just a general feeling of, tiredness, and malaise is a general feeling of being unwell. If you've ever had a friend with pneumonia or pneumonia yourself when you were younger in school, you see that they take about 3 weeks off of school. So it's quite a bit of time. And when they cough, that you will see exudate that is containing pus. It's purulent, and definite pain on respiration / when we're talking about breathing, we're going to call that ventilation. So diaphragm up and down, air in and out. All right. So the treatment of this is going to depend on the cause. If it is a bacteria, you can use antibiotics. Antibiotics don't do anything besides kill bacteria. So if it's not a bacterial cause, then you don't want to use antibiotics. There is a lot of resistance to them. The diagnostic criteria that's a little bit different in pneumonia than anything else is crackling. The lung sound associated with pneumonia is crackling, which doesn't sound like crackling in like a fire crackling. It sounds more similar to the sucking up of the bottom of a milkshake out of a paper cup. It's a really great gross sound. So if you're looking at word or symptom association, crackling in the lungs is supposed to clue you into pneumonia. All right, it looks like the same individual from the prior slide with pneumonia has now caught tuberculosis, which is bad for him. So tuberculosis is a highly contagious respiratory disorder, and there is a value we refer to as the R naught, so an R0, and the R naught tells you the transmissibility of a disorder. So that tells you, like, if one person has a disorder, if there's an R naught of 1, for example, it means that they can, typically infect one other person. If there's an R naught of 4, it means that one person can infect 4 people. So the R naught of tuberculosis is relatively high. It's highly, highly transmissible, meaning if this individual sneezes or coughs, we see a widespread passing of tuberculosis to other individuals in the area. We see this also with COVID-19. There is a pretty relatively high R naught value with this. And when we were first trying to figure out, like with COVID, how it spreads, we were looking at R naught values that were very similar to tuberculosis. So we wanted to treat it in the same way we would tuberculosis. TB is caused by a specific pathogen, Mycobacterium tuberculosis. If you've ever been tested for tuberculosis, they inject an activated form of something called tuberculin underneath the skin, and you wait to see if there's an infection, which tells you that's a type 4 sensitivity reaction or hypersensitivity reaction, which is your cell-mediated delayed type hypersensitivity, so you're type 4. So again, this is an airborne transmission, so coughing, sneezing, putting stuff in your mouth and then sharing it with other people. And in this case, that pathogen, this Mycobacterium tuberculosis, lands itself in the alveoli, and this is a chronic type of inflammation. Remember, inflammation can be acute or chronic, and in chronic inflammation, there's either non-specific, meaning it's just inflammation that lasts longer than 3 weeks, or there's granulomatous, which is chronic inflammation associated with the formation of granulomas. An oma is a growth, and the Latin for growth is tumor. That shouldn't let you clue you into the fact that it's cancerous. It's not. Granulomas are converted epithelioid cells, which become fibrotic. They become covered in fibrin. which makes up scar tissue. And scar tissue isn't something that just goes away or resorbs, it stays there forever. And that's what you see in these lungs. We have these fibrotic cores. There's also something that's characteristic in pathology, the Gahn complexes, which refer to these areas of reactivation in the lungs that lets you know, like, once this resolves, the pathogen can be reactivated at different points in time. And when it does reactivate, we see damage in the apices, which is plural for the apex of the lungs. And when it does reactivate, we get this necrosis at the center in the apices, in these areas of granuloma formation. Also, because this is a hypersensitivity, we see this widespread fibrin accumulation. So this is when, remember, we have organ degradation and necrosis here, and organs are really high in tissue factor. And tissue factor, remember, is what starts the coagulation cascade. So as this parenchymal tissue is broken down, we get tissue factor released from that area, and the coagulation cascade is really just pieces of things that are present in the bloodstream. So we can see this overactivation of the coagulation cascade and then the lodging of this fibrin in other places, like the glomerular capillaries of the kidneys, in the marrow of the bones. The kidneys and the bones, they both have a specific type of capillary that are leaky. We can also see this accumulate in the fallopian tubes, which would alter ovulation and then implantation. Again, this can heal, but we do have this scarring because fibrin doesn't go away, and it can reactivate. And when it does reactivate, we see that damage occurring in the apices of the lung, so the top area, and you get necrosis at the center, release of tissue factor, and then activation of the coagulation cascade, and then effects in different, what we call these fenestrated or sinusoidal capillaries, which alter the system. So highly contagious tuberculosis, and we can test with this by the tuberculin injection, looking for hypersensitivity reaction. All right, more kind of parenchymal disorders. We have the first step in these chronic airway diseases referred to as small airway disease. And remember, in medical physiology, when we're talking about airways, we're talking about the bronchioles. We're not talking about the trachea. So small airway disease starts when there is chronic exposure of tissue, specifically the epithelial tissue on the inside of bronchioles. Remember, that's squamous tissue. And we start to see some changes of that tissue. So we first start to see, remember, if we think about cellular injury, we start with hypertrophy or hyperplasia, which can move into metaplasia, and then move into what we call dysplasia, which we call whoopsies, and then into neoplasia, which is cancerous. So this is really the first step of that, where we're inhaling these abnormal things, these irritating substances like smoke, like tar, and that starts to thicken and make fibrous these bronchial walls. You see this in smoking and also secondhand smoke, which is being in the same room or vehicle with somebody who is smoking. It's not walking by somebody on the sidewalk who's smoking a cigarette. That's not enough. That's a cigarette, not a stick that's smoking. That's a cigarette. So that's not enough for secondhand smoke. So it has to be constant exposure. So small airway disease, you can actually see it in imaging. We see these fibrotic areas. And if we don't have the removal of the irritant, which, remember, if you remove the irritant, everything up to dysplasia can still go back. It's adaptive changes and reversible changes. But once you make it to neoplasia, we cannot go back. So we start to see changes which can eventually lead to metaplasia if not resolved. And that's what we see in these next disorders. And then like bronchitis. So chronic bronchitis is a little bit different than acute bronchitis. And acute bronchitis is acute inflammation of the bronchi or the bronchi. So here, inflamed bronchial tube. And that occurs due to viral or bacterial causes, and it's a lung infection causing, inflammation, coughing, shortness of breath. When this lasts for greater than 3 months, we call that chronic bronchitis. And we see this generally after 10 or more years of smoking. And I say this all the time. I'm an addiction scientist, so I love talking about drugs of abuse. Cigarettes are interesting because you either see people who smoke not a lot, so maybe they smoke 1 to 2 a week. We call those people chippers. So they never buy their own cigarettes. They're always bumming them. Maybe they only smoke when they drink. Or we see people that smoke a lot, like 1 to 3 packs a day. And that's a lot of cigarettes because a pack is 20. So if you have a patient smoking 3 packs a day, that's 60 cigarettes in a day. That's a lot, right? So we see constant irritation, inflammation of these bronchial areas. And remember, they start to undergo change in this typical pattern. So starting with this, hyperplasia, hypertrophy of the small airways, and then them becoming thicker to protect the tissue. Chronic bronchitis is characterized by this metaplasia of tissue, and meta means change, and plasia means substance. So a change in the substance. Here we have a normal, healthy inside of the bronchioles. We've got our squamous cells, and in this epithelial tissue, we have goblet cells, which make mucus, and goblet cells also go with ciliated cells. And remember, it's their job to move the mucus. We call that clearance. So goblet cells make mucus, so we've got mucus here, but that mucus needs to move. Over time, what you see is metaplasia, where we have an increase in hypertrophy of these goblet cells, meaning you're going to have more, that's supposed to be a G, you're going to have more mucus, but you see a change in these epithelial cells where they become thicker, but you'll see that they lose their cilia, which means there's going to be inhibited clearance of the mucus, meaning that it can accumulate. And like urine, mucus is fine as long as it's moving. When it becomes stagnant, that's when it starts to pick up bacteria and cause recurrent infections. So if there's no cilia for clearance, that means the person has to engage in their own clearance, which is coughing. So you're going to see that as one of the main symptoms and signs in individuals with chronic bronchitis. Because of this metaplasia, we have this increased coughing. It is definitely a productive cough because we have the hypertrophy and hyperplasia of these mucus glands. But again, at the pathologic level, metaplasia, a loss of the cilia, a loss of clearance, lots of coughing for individual clearance because the mucus overwhelms the ability of cells to remove it. And when mucus starts to stagnate, then we get infections. So chronic bronchitis caused by generally smoking, but also inhalation of other things like exhaust fumes, whatever else that doesn't belong in the lungs. We want to inhale atmospheric air, which is 21% oxygen. We ideally don't want to be inhaling large amounts of anything else. So that's chronic bronchitis, metaplasia, cough, lots of action. All right, so since we're mentioning cough, one of the things that can happen in extreme coughing, and when you cough, I mean, we're talking lots of force. I mean, I think I read, what was it? Might be totally wrong, but like 35 miles an hour of force when we're coughing. So we can really generate a lot of force when we cough. When coughing is too pronounced, we can start to see damage to the airways. So they should look like this. They should have a nice little lumen. They have the epithelial wall. They've got smooth muscle inside of them. But when individuals cough too hard for too long, you can physically strip and then dilate these airways, these bronchioles, and we call that bronchiectasis. So just like atelectasis, we had a plugging of airways with something like mucus or a foreign body. Bronchiectasis is when we force air too quickly into the bronchioles with too much force, and it dilates them. And unfortunately, once you have this dilation, it doesn't go back to the way it was before. It's a permanent change. So we want to do things like limit coughing, limit the force of coughing in disorders like chronic bronchitis, thin the mucus, increase airflow so we reduce the coughing and then reduce the chances of bronchiectasis. Same thing in pneumonia. Not only can individuals, break those break those ribs, which if you've ever seen or had broken ribs, they don't do anything for them. They might put some tape on there and they're like, look, I fixed it. Here's some tape. Well, guess what? That doesn't heal it. It's just going to hurt really bad. But also if the cough has too much force, we can see this irreversible bronchiectasis. And this is what it looks like. So here's imaging, and we see these dilated areas of the bronchioles. This, especially in this picture, we can see this really nicely. Same thing with aneurysms. They can be saccular or they can be fusiform. And fusiform means a bilateral dilation. So on two sides you have dilation. So this is a fusiform dilation of the bronchiole. On the right side, remember it's like a patient lying on the table. So they're laying like this. So right side, left side. So we've got normal bronchioles over here, and then we have a dilated bronchiole. And remember, this doesn't go away, and this also is going to lead to the accumulation of mucus. And remember, if it's not moving, it stagnates, and once it stagnates, it picks up bacteria. So we see, because of the disruption of these walls and the retention of of secretions of mucus, we're going to have the reflex of coughing to try to clear this, because if we have inhibited clearance physiologically, then we have to engage in physical clearance, which is coughing, right? We need to clear those airways. When the mucus accumulates, it's bacteria. We see infection, so repeated bouts of infection. This, what you're looking at here, this is the best way to diagnose it. We see a bronchogram, so we can visualize the bronchioles. And the only way to treat this is to resect that area. So you would have to physically remove that area of the lungs. Good news about that is we've got 2 lobes on the left side, 3 lobes on the right side. You can take out a lobe and still have pretty good function. You can take out a full lung. You'll have compromised function, but we can still have good respiratory long-term outcomes with 1 lung remaining. Whenever you remove something, we call that a whatever-ectomy. So we can have a lobectomy, or we can have a pneumectomy, which is a removal of a lung. Ectomy means to cut out and remove, where otomy means to cut into, like a lobotomy with an ice pick into the brain. That's a lobotomy. All right. The last parenchymal disorder is emphysema. This is another irreversible change because it's a change to the structure anatomically of airways. When there is emphysema, again, there is long-term inhalation of irritants. Really commonly, you see this with long-term smoking. And in emphysema, there's two issues. The first issue is that we have, because of the small airway changes that exist first, that's going to limit the elastic recoil properties of the lungs. Because the lung and all of its tissues are high in elastin, it can dilate and then contract so it can go back to its normal size. When we have fibrosis, or the accumulation of fibrin in tissues, we lose some of that elasticity, which is going to narrow the airways. As a protective mechanism to maintain airflow, we will see the dilation, like through smooth muscle activity, of these airways. Remember, when air flows in too quickly, we can have dilation of whatever it's flowing into. That is exactly what you see in emphysema. So we see airflow in too quickly because, remember, the first problem is the dilation of these bronchioles. So dilation of bronchioles. When air flows in too fast to the alveoli, they look like grapes, but they are not, individual grapes. They're kind of connected, and they're connected to one another, or separated by septi. So just like you have a septum between your left and right nostril and your left and right heart, there's septi between the alveoli, or alveoli, however you want to say it. When this airflow increases in emphysema, it destroys these septi. When that happens, instead of having nice open air sacs like this, we break down those septi. It would be the same as if I punched you in the nose. That's a nose. That looks pretty good. And destroyed your septum. Your nose would kind of look like this. It would lose its structure. And that's exactly what we see in the alveoli. Instead of the septi there, the septi break down, and then we just get collapsed alveoli. And when they collapse, we are losing a large part of the respiratory membrane. Because remember, the respiratory membrane, what's going on here? The respiratory membrane is the type 1 alveolar cell and the capillary around it. So if we lose this type 1 alveolar cell and the septum, and these all merge together, we've lost a huge amount of that surface area for gas exchange. So that's going to make breathing a lot more difficult, a lot more labored. It's going to be very difficult to get air in. So we see these long-term changes to the chest wall. Emphysema involves a lot of energy in inhalation, so you end up utilizing a lot of that energy. So it tends to favor weight loss. So weight goes down, alveoli collapse, bronchioles are dilated. And again, this is irreversible. So ideally, what you would want to do is prevent it through things like smoking cessation, therapies, to prevent this from happening in the first type. Pathologically, you can look at the cell type. That's not going to be our focus. Centriosinar, Panasinar are the two different pathologic types of emphysema. But again, we're going to see this characteristic low weight, dilated bronchioles, and the changes in the pulmonary function tests that reflect a hyperelasticity. We see hyperelasticity because of this difficult airflow into the alveoli. the individual has to bring in a lot of air, so they end up hyperinflating the lungs, and that is going to break down the elastin in the chest wall over time. It's kind of like stretching out a rubber band over and over again, and then kind of wearing it out over time. So we see changes indicative of that, where if you're looking at vital capacity, for example, it's a very quick inhale or exhale. And a fast removal of air. All right, so those were parenchymal and pleural disorders. Stay tuned for more. Stay smart.